So Paul, would you like to do our introduction for today?
Sure. As an imaging scientist in breast imaging instrumentation research for many years, it's a real pleasure to introduce an actual breast imager who also studied as a pediatric radiologist as well as women's imaging. And it's interesting, I think quite a few women do that. Well,
A lot of breast imaging and a lot of peds, yes,
Yeah.
not usually together.
I'm thinking of what's her name? Lives in our Laurel Gardens, so. Anyway, so,
Carolyn Blaine. probably.
yeah, Carolyn Blaine, yeah,
She was one.
yeah. Anyway, most of you know Kim better than I do, having been around longer than I have at United Methodist Church, but she served in breast imaging for about 25 years at former St. Joe's Hospital, and now she was at University of Michigan until she retired this summer. It's just a real pleasure to have someone talking about breast imaging, and that there are a lot of relations between science and doing the right job on medical issues. Particularly in this time when there's a lot of false information out about vaccinations and even screening.
Oh, yeah.
And so, welcome. Thank you, Kim.
You are so welcome. How fun, the three of us actually work in the same department. How rare is
How did we
that?
happen to think of
You two are scientists and I'm the one on the ground with the patients. Yeah, I think that's amazing.
Well, Jennifer made you a PhD this morning.
She
so-
did, that was great, that was easy. Do you want me to advance slides? or
I
do
can,
you wanna do it?
sure,
Okay.
yeah, sure.
So I am the former division director of breast imaging at U of M. It was during COVID. That was quite a delight. And retired, I'm a retired adjunct professor now for U of M. So you can advance. Okay, so the first thing I thought we would go back to our Wesley quadrilateral that we're all familiar with: scripture, reason, tradition, and experience, and start with scripture. So why are we doing a talk on breast imaging and breast cancer screening? So went to scripture and found a verse in John that said, "Beloved, I pray that all may go well with you and that you may be in good health just as it is with your soul." So health is important. And in 1 Corinthians, "Do not know that your bodies are temples of the Holy Spirit who is in you, whom you have received from God? You are not your own, you were bought at a price. Therefore, honor God with your bodies." So we talk about our body as a temple. That's a likely source, so that's really important to start there. We'll talk a lot about reason and scientific explanations of what we do. I can speak a lot about what is our traditional practice and our standard practice of care, and of course, experience. But most importantly, I thought it would be a good way to start. You can advance. This is how many of us feel as we're about to approach our mammogram. And many of us joke that it must have been a man that made these machines.
Yeah.
And yes, exactly. And you can second that. Mammogram next. Welcome to the machine. Joyce Meyer says, "You never really know yourself until you see yourself under pressure." And I always wear a t-shirt the day after my mammogram that says "freshly squeezed." So you gotta have a sense of humor about this. Okay, so we'll go on to the next. So what is the purpose of this presentation? Why do we screen for breast cancer? How do we screen for breast cancer? What do we recommend? What are the current recommendations? A little bit about diagnosis and treatment. Certainly, I'm an expert at diagnosis, treatment, not so much, but I just learned from my colleagues. And then some key questions about what we can do to prevent breast cancer. And questions, I don't call them answers, but more opinions at the end. And hopefully I have about 15 slides, so we'll have lots of time for your individual questions. But I needed to get us on the same page where we're starting from, okay? All right, this is why we screen. 1 in 8 women. So how many women of us are in this room? One of us will be diagnosed with breast cancer in their lifetime. Per individual, all comers, Our lifetime risk of getting breast cancer is about 12%, 1 in 8. It is the most commonly diagnosed cancer in women worldwide if we do not count non-melanoma skin cancers. And as third world countries become more industrialized and more westernized and their diets change and women live longer, this is going to be a global health crisis. So women that move to the States change their diet, change their environment, like Japanese women, when they move to the States, their risk of breast cancer goes up. All right, second most common cancer death in women. Lung cancer is still more deadly, but breast cancer is more common. So 1 out of 39 of us will actually die from breast cancer. But here's the one sentence I want you to take away. Size matters. And I do not mean in football stadiums. I mean, when we catch breast cancer, it makes all the difference to whether or not you're going to survive long-term by how big it is when we find it. And the only way to find it small is through screening. So that is the take-home message. The sooner you find it, the more likely you're going to be cured. And I mean real cure. So if we look at all studies about how breast cancer screening has reduced mortality, it depends, there's a gazillion studies out there. I don't have the sophistication to argue the epidemiology like these scientists do. But I'm going to tell you, our ability to save women's lives by implementing breast screening through mammography has decreased mortality by about 50%, which is an amazing public health achievement. So how do we screen for breast cancer? Breast physical exam, not great studies about how good it is in catching things. Usually by the time you can feel it, you know, sometimes you pick it up small, but most of the time when you feel it, it's gotten a little too big by the time you can feel it. It's still important. Still try to remember to do your breast physical exam. Have your doctor's exam once a year. Mammography is the standard of care. So mammography is an X-ray. It's a fancy X-ray with very high resolution. Standard mammograms are 2D, what we call two-dimensional. Fancy mammography X-ray is 3D. It's like a CAT scan of the breast where we rotate the arc of the machine. And when you have a mammogram, you know you're getting a 2D when you're in there positioned and it goes, eh. You know you're getting a 3D when it goes, na 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 na, eh. Seriously, that's the difference. That is the difference. 3D versus 2D.
It's the song.
Yeah, it's a song. Yeah, yeah. And there usually is a beep to know you've gotten maximum compression. And my goal is always to get to the beep. Hold my breath, get to the beep. It's going to be quick, but you're going to get a better mammogram if you can get to the beep. All right, ultrasound is great. I love ultrasound. I'm an experienced ultrasonographer with children especially. The more fat we have, the worse ultrasound does. So that's why ultrasound is great with kids. It's actually better for smaller, dense breasts than bigger, fatty breasts. Ultrasound is an amazing tool to use when somebody feels something, but you don't see something on the mammogram. It can be used for screening. We'll talk about that. But it's a tool that I would use almost on every patient that would come through mammographic finding. We do an ultrasound in that area. So ultrasound is an amazing tool. MRI is really, nothing beats MRI right now for finding breast cancer. Nothing is better than that. It's expensive. It's hard to get access to it. The world doesn't have access. You need an IV line and you get gadolinium dye. We know gadolinium deposits in your brain and your bones. Right now, we don't think it does any damage. Who knows? It probably doesn't. Molecular breast imaging is something not done very commonly. It's not done at St. Joe's. It's not really done at the U. It's down in Toledo. So if anybody wants an MBI, There's one place, Assess to Maybe Breast Exam. Toledo is really one of the groups that puts out a lot of papers about it. So MBI, kind of site specific. Contrast enhanced mammography is when you get that mammogram, but now they're gonna put an IV in you and they're gonna put an X-ray dye, just like when you get a CAT scan. And it's really probably gonna compete with MRI in the future. Without needing to go into the MR scanner, because if you have metal in your body that can move, you can't go in the MR scanner. It's expensive, it can make you claustrophobic. So contrast enhanced mammography is coming down the line. U of M just got it and they're experimenting with it now. Thermography, not something that I can recommend from a medical standpoint. There are, places that use it. We don't know what to do with it. We can't biopsy anything on it. It's not a replacement for mammography. CAT scan and PET scans are not used to screen for breast cancer, but sometimes what happens is you have a CAT scan or a PET scan for something else, get in a car accident, and then they find a breast mass. Or a PET scan, they find a breast mass. So again, not used for screening, both require radiation, both are too expensive, but we can find things on those modalities. Any questions about modalities before we move on?
Could you say a little more about molecular? What does the molecular mean in this context?
It's nuclear tracer. So instead of an X-ray machine or a CAT scan will deliver radiation to the body from a machine outside of the body. Nuclear imaging, and you guys can laugh, I know.
No.
You can help me with this. Nuclear imaging, you're gonna inject a substance that's radioactive. And then you're going to use a gamma camera to pick up what the body does with it. So nuclear, like if you get a bone scan, a liver scan, those are nuclear tracers where the radiation comes from the stuff you inject, and then you pick it up with a gamma camera, a specialized camera. And there are specialized cameras for breast imaging. MBI is not something that I would say is widely available or widely used.
It's about 10 times the dose
Yes, it is.
of a mammogram.
Yes,
And the mammogram is only to the breast, but
Yes.
the molecular imaging goes to the whole body.
that's exactly right.
On the other hand, it is very specific, and so they've got some fairly good results, I think.
And some decent
But-
results. yeah.
But why do you need that when you've got ultrasound and MR?
When you've got
Right
MR.
there?
If you may use it, let's say
Contrast.
you're a high risk patient, you can't go in the MRI because you've got metal or you've had an ultrasound. We'll talk about the utility of ultrasound for screening, but you want something more. You could go get an MBI down in Toledo, and if it's negative, great. So it could be an alternative for MR if you can't have one. And before contrast mammography comes on board. Okay, next slide. Yep.
What about biopsies, like fine needle aspirate biopsies? Is that part of, like, I've had a biopsy as
Yes.
a result of a suspicious mammogram.
That's right. And we're gonna get into that.
Okay, all right,
That's not used for screening,
okay,
but it's used for diagnosis.
okay.
Absolutely. It's critical for diagnosis. Now, notice there's no blood test for breast cancer. Prostate cancer, get PSA test. There's no blood cancer test. So there's no test your doctor can draw, unlike the guys here, who if you get a PSA test, and there's a lot of controversy at the PSA test, but at least you have something. We don't have something for breast cancer or ovarian cancer. That's great. Okay. Mammography, pros and cons. Pros, widely available. Almost any decent radiology place has mammography available. There's no injection. It's relatively inexpensive, a couple $100. Usually insurance will cover it. If you don't have insurance, there are special programs that will cover you for the screening as well as the diagnosis and the treatment. There's special programs for that. We have decades of experience with mammography. We've been doing this since the 70s. What we look for in a mammogram is a mass, an area of distortion, which I call a spider. It looks spidery. and calcs. A mammogram is really the only thing that can find little tiny deposits of calcium. So you have to have a little bit of OCD to be a mammographer because you are looking for 1 to 2 millimeter calcifications on every mammogram you read. Can you imagine? Yeah, you gotta be kind of a prickly OCD person to do that, yes.
Yeah, the rule of thumb that I've heard is
Yeah.
that you pick your mammographer based on how many exams they've done, and if they haven't done more than 10,000, then you don't want them.
Yeah, you have,
That's how many
Yeah,
exams.
you gotta-
That's,
well, you are right, you double read, yeah, and you just have to get experience. We'll talk about more of some of those nuances. The only screening method we have where we know it reduces mortality. It involves radiation. Now, it's about 0.3 millisieverts a year. You and I breathing and living in this area, we get about 3 millisieverts a year. Healthcare workers can get up to 50 a year. I've never come close to that. But just living, we get 3. If we lived in Denver, we'd get more. If we take a plane ride, we get more radiation. It's all cosmic radiation. So that's an average dose for about a mammogram. So you can see it's about worth 7 weeks of living. So when people say I don't get my mammogram because of the radiation, nah, it's a silly reason not to get mammograms. Obviously, there's some discomfort. For those that are really bothered by it, I say take a little Tylenol or Motrin before your exam, get it in the first week after your cycle, when your breasts are less sensitive. You know, it's a quick beep. Experience matters. That's your 10,000. So if you have people that are doing all of radiology and reading 500 a year, not great. If you go to a dedicated breast center, like at the U, like at St. Joe's, where people are reading them every day, all the time, it's better. We do have artificial intelligence that reads with us. We've been doing that for at least a decade. If you're an experienced mammographer, it rarely adds anything. If you're a less experienced mammographer, it helps. Most of the time, you're getting rid of stuff that doesn't mean anything. So there's a lot of noise and chatter in the AI right now. But maybe in the future, because we don't have enough mammographers in this country, let alone the world, maybe in the future, AI can read our mammograms. So we'll see what happens with that. And you all heard about dense breast tissue, the sensitivity of mammography, the more whiteness you have in your breast, the less sensitive it is. So if I am a fatty breast, I can see a 5 millimeter cancer with ease. If I'm looking at a patient with dense breasts, I can't find an elephant. I mean, and that's just the way I have to explain it to patients. It's that big of a difference. And can you tell by feeling? No, I feel like all fat and I'm heterogeneously dense. So your radiology reports are by law mandated in the state of Michigan to tell you what your breast density is. Okay, let's go to the next slide.
Okay,
Yeah,
so what's the way for a person with dense breasts then to get a better care, better reading?
we're gonna talk about that.
Okay.
And that's a key question. Thank you.
Okay,
That's a key question. So if you're fatty, I mean, a pure fatty breast is a delight to read. We call them breast sorbet. Because in between dense, busy breasts, oh, I got a sorbet. And I mean, it's that much of a difference. So I can find a 5 millimeter cancer easily. Scattered, pretty good still. My sensitivity is gonna be up there. Heterogeneously dense, you can see my sensitivity is starting to fall. You got more white stuff, more glandular tissue, more fibrous tissue. Dense, oh, 50-50 chance I can flip a coin. Now, I can still see calcs pretty well, and that's where I'm gonna add some ultrasound. If somebody comes in feeling something, we'll do the mammogram, we'll do 3D for sure. We'll do the ultrasound in the area the patient feels. And sometimes be a little more generous because we know that we could easily miss stuff by mammogram. This is a really nice article. If you want to look at screening algorithms in dense breasts, This is a really nice article. I'm gonna send out this slide deck for you guys to have it by email, so don't worry about taking notes. So you can see 10% of women are pure fat, 10% are pure density. Most of us fall in the category of scattered versus heterogeneously dense. As we gain weight, we tend to add more fat to the breast. As we lose weight, we tend to get a little denser. As we go through menopause, because we don't have hormonal stimulation, we get a little fattier. So that's a benefit. But about, if you're on the fatty curve, the dense curve, those are the extremes. In your mammogram reports, the next time you get a mammogram, look at your report. It'll say, most of the time, it'll say scattered or heterogeneously dense. If you see the word just dense, like dense breast tissue, ooh, alarm bells should go off. You need to probably talk to your doctor about, is there more I can do? Because our chances of finding something in your breast are close to 50-50.
How do they measure sensitivity in mammography unless they're doing it with MR? To know what
How
you
good
missed?
it is,
Yeah.
they look at like 1 and 2 year follow-ups
Yeah,
and
yeah.
that kind of thing. So
Yeah.
they give it some time lag,
Right.
yeah.
At 71% for dense breast seems.
That's as good as it gets.
Yeah.
That's as good as it gets,
Yeah.
optimistic.
Yeah.
I'd say it's
me.
50-50,
Yeah.
right?
What is a dense breast? I mean, how?
A dense breast, when I see it on a mammogram, it looks like white, just
And what
pure
causes
white.
that?
It's just glandular tissue.
It's, what's interesting is somebody with large breasts or small breasts will have the same amount of glandular tissue. What varies is the stromal connective tissue, the fibrofatty tissue. So if you have very little fat, like for instance, typically Asian women that come in that are very thin and they have much more dense tissue, you take a mammogram, it's white. Whereas, somebody that has a larger volume of fat, and some of it's just genetic, how we're made. It'll be like this beautiful gray where you can see white specks super easily. But you can imagine a sea of white, how are you gonna find tiny calcifications in there? Or masses in there? It's very difficult. So that's the truth. Okay. So this is a really important slide. It comes out of this, this is hard data to put together, and that's why I picked up this panel review. So if I'm sitting down in front of a bank of 1,000 mammograms, I know I'm gonna find 4 cancers, 2 to 6, typically 4. And all of us as breast imagers have statistics, like we get report cards every year. What is your cancer detection rate? What is your sensitivity? What is your biopsy rate? I know when I biopsy what my likelihood is, just like surgeons have statistics. Because we want to catch the outliers, callback rates. I know my callback rate is 8.2%, which is good. If it's 30%, that's not good. I'm calling back way too many women. So we do have metrics that help us with detection. So I sit down at 1,000 mammograms. I know I'm gonna look really, really hard at 996. They're going to not have cancer, 4 will have cancer screening. If I add 3D to all of those exams, those 1,000, I'm gonna find 1.7 to 2 more. So does 3D help? A little. What it really helps with, it reduces your callback rate. So it increases your sensitivity and reduces your false positives. If you were a heterogeneously or dense breast, I would get it every time. I'd add it. The radiation dose is now the same. The time you get the you're gonna hear that, it's worth it. It's gonna undo some of the overlap slightly, but it's not a miracle. It's not adding a ton. Ultrasound, if we do whole breast ultrasound screening, now that's not somebody that comes in with a complaint, but we use either a machine to do it or a tech to do it. It's gonna add 2 to 2.7 per 1,000. So again, a couple, but ultrasound is gonna add a lot of false positives, a lot of ditzels. I'm not gonna know what to do with, that are either gonna have to be biopsied or followed. Great tool, and the problem with ultrasound, so many images, tech dependent, we do not have the manpower to do breast ultrasound. Breast MRI, look at that number. 16, it finds 16 additional cancers.
On a new set of patients that haven't been screened recently.
Yeah, it depends on which population, yes. But it adds a lot. So MRI is our golden tool. It too will add a lot of false positives. So you're gonna get an MRI, you're gonna find stuff you're not gonna know what to deal with. You're either gonna have to go into short-term follow-up or get a biopsy, either by ultrasound or on the MRI machine. Not easy. Expensive, not always covered by insurance, requires an injection. And you can't be claustrophobic. So MBI and CEM, the nuclear one adds about 8. Contrast enhanced mammography, probably 10 to 11. Now, this was 2021, 3 years ago. Technology continues to get better. And all of these depend on the population you're screening. So I do want to give that a caveat. But MRI is the goal. That's the goal.
Are these all adding on the 5?
Yes,
Okay.
yes, these are adding on to the 5.
This is scary.
It is scary. What part is scary? What are you thinking?
Well, because I get my annual 3D mammogram.
Great,
Shouldn't I be? But now are they not finding everything?
Right.
and we're gonna talk about that. We're gonna talk about that. Great, hold that question.
I've got a question on the. Why not be developing contrast enhanced ultrasound with a contrast agent that leaks out of the vessels like iodinated
Mhm.
or gadolinium
Yeah.
does. Then you've got the soft tissue visualization of MR
Mhm.
and the vascularity of MR.
Sure,
You've got as good a resolution as MR. I just think that radiology should be pushing that more, but then that's why I work there.
and I love ultrasound. Ultrasound is incredibly operator dependent. You need somebody that knows what they're doing. It's not like a mammogram or a CAT scan. The tech comes in, does the mammogram, you pretty much get what you see. Ultrasound, I get what the tech shows me. If it's a great tech, I'll get great, I can really rely on her. If it's not a great tech, an inexperienced tech. Well,
But you would have it, if you start doing contrast enhanced ultrasound,
yeah,
you would have experienced techs pretty soon. And
yeah, it takes the big issue with that is
well, you'd want to do it.
the
you'd wanna
number
do it
of
automated,
images.
automated.
Yeah, you'd have to do it automated.
Yeah.
The number of images, enormous, the injection. So every one of these tools has pluses and minuses. What we do is we add them all together to help. Okay, next page. All right, so here's where things get tricky. I bet you are all confused about when you should start a mammogram and how often you should get one. Okay,
I've been turned away by my doctor saying you're too young.
you're too young.
Yeah. Even though I asked for it and I was advocating for myself, they're like, I'm sorry, you just won't do that.
And the question is, did you go in with a problem or
I
did you
did.
want a screening?
I did. I was like, I feel something in my chest, blah, blah, blah. I like, blah, blah. She's like, you're young, your breasts are lumpy, go away.
I would not recommend it. I would say, at least get an ultrasound.
Yeah.
Yeah, I mean, my daughter had a mammogram at 23. I don't ignore what patients say,
Yeah.
Or maybe find another doctor.
Yeah.
and I'm always careful because I don't know what happened in the exam room, what they were feeling, et cetera.
Right.
But ultrasound's cheap and easy, and we can say something's there or not. So, all right, so this is why it's confusing. We used to say, when I started mammography, we said, get a baseline of 35, and then starting at 40 every 1 to 2 years. Then, there were recommendations, forget the 35, start at 40, get them every year, and then this, USPSTF, very controversial, came out with guidelines that said, nope, start at 50 and do it every other year. And medical societies went berserk about this, berserk, because we knew patients were gonna die from breast cancer. And there has been such pushback about those recommendations. Some of them were like, oh, what made us really have a hard time was like, women are too fragile, they can't handle a false positive. Baloney. Baloney, they can handle it, it's okay. Cost. You know, how do we implement this on a screening? But there is no question, if what we care about most is saving lives from breast cancer. For an average risk patient, you start at 40 and you screen every single year. You do not miss a year. And it's because subtle changes can start happening on those mammograms. 2 years is a pretty big lag time, especially in your 40s. So there's been a lot of confusion about this, and all these different societies have basically different things. But the American Cancer Society, NCNN, and I really highlight that, that's what we use. And ACR is the American College of Radiology. Now, some people will say, well, you're just trying to cash in on the mammograms. So, you know, but believe me, you know, we
don't make a lot of money.
We don't make more money when we do more mammograms. Right. So, but the bottom line, start at age 40, screen as close to yearly as you can with mammography, because a 5 millimeter tumor is a way more treatable, way more curable than a 1.2 centimeter tumor. Okay. High risk patients. So they say around age 25, you should have a sense of what your breast cancer risk is. So young women in their 20s need to ask their moms, sisters, daughters, know your family history about breast cancer. And if you have a history of radiation, let's say you had Hodgkin's disease, and you got chest radiation, big risk factor. If you have a known genetic abnormality in your family, BRCA2, BRCA1, there's many others, another reason to make you high risk. But typically the easiest thing, if mom, sister, or daughter had breast cancer before the age of 50, that puts you in a high risk category. Okay.
Red ants.
Ants, it depends on how many ants and where are the ants. So primary first degree relative is the key. Mother, sister, daughter. Now, if grandpa had breast cancer or your dad had breast cancer, then we're talking maybe a BRCA2 thing. So do know your history, not only in your immediate family, but beyond that. Right. You had 3 aunts, but they were all 55. You still had 3 aunts that died of breast cancer. You want to know that. Okay.
So the implication is that there's a connection genetically to the probability of getting breast cancer.
Yes. We say right now that there's for the breast cancers that get diagnosed, about 5 to 10% are related to a genetic abnormality. And I always caveat that with that we know of. Okay, so it used to be BRCA1 and BRCA2. Now we have all these others, the PELBs, the CHEK2s, etc. So every year we develop more, and we understand more about cancer biology. So there is a risk, but the worst thing to do, and I hear this all the time, I don't need to get my mammogram because I don't have a family history. Wrong answer. Okay, I hear that all the time. Because 90% of breast cancer is in people who have no family history.
So
That's a good statistic. to hear.
That is the main thing. So do not use, I don't have it in my family history as an excuse not to get your mammogram. Okay. So if you are high risk, so you talk to your doctor, and now they recommend that instead of self-breast exam, they call it breast awareness. You know, it takes 30 seconds to do a breast exam in the shower, last day of your menstrual period, no big deal. And if you have a problem, don't blow it off. Go to your doctor. If they want you to come back in a month, fine, but we can do an ultrasound. It's cheap and easy, and it can be very reassuring. Supplemental screening is best done with MRI. And sometimes we start mammography as early as 25 or 30, depending on when mom was diagnosed with breast cancer, or if you had radiation as a kid. And we're seeing more and more of that as we have lifelong cancer survivors from pediatrics. And if you have any questions about genetics, just go to a genetic counselor. That is the key. Okay. All right, so we consider average risk people as a less than 15% lifetime risk of breast cancer. Remember that 1 out of 8, that was 12%. High risk is greater than 20%, so that mother, sister, daughter, less than 50 will put you over that. If you have a BRCA gene, other genes will put you over that. We don't know quite what to do with these moderate risk people between 15 and 20. Wendy?
I have a question from the chat from
Great.
Mary McCluskey. Did you say 9 or 90% of breast cancer are in women without any family history?
90%. Yeah, so do not rely on, I don't have breast cancer in my family. Only about 10% is related to genetic causes. Okay, so most of us are gonna be in that less than 15%. I'm gonna tell you how to figure that out. So if you're in an average risk, we don't recommend, there's no society that recommends getting supplemental MRI, okay? Annual mammography is the best way to do that. If you feel anything, you go in, you get another mammogram and you get an ultrasound, okay? But we do not recommend supplemental screening with MRI, ultrasound, or other. I get a yearly 3D mammogram and I have total access to MRI. I've never gotten a breast MRI. Okay, so I'm not just saying this, you know, this is personal too.
What if you've already had breast cancer?
Great question. So some of it depends on the age of when you got it. Some of it depends on the cell type and the biology, and if you had a genetic abnormality. And I'm gonna come to that, because that's a gray zone right now. That's a gray zone. Okay, let's go on to the next one. Who's considered high risk? First degree relative, diagnosed before menopause, a known genetic condition, chest radiation before 30. And you'll see I put question marks on these other things, because this is a little bit controversial in the literature. What do we do with these patients? You had a prior breast cancer, right? So what do we do with you? If it was prior to age 50, it was over age 50, it was a low risk cancer. Typically, we're not getting breast MRIs on those patients. Higher risk biopsy, if you had a history of LCIS atypia. Another, you know, if you've had this in a biopsy, you probably know it, and they may do things with that. Black women are at terrible risk for breast cancer. Their breast cancers come earlier, they're more aggressive, and they're more likely to die. So there is a huge push to get African-American women screened, and churches play a big role in this message.
Did they
Ashkenazi
start at 40?
typically start at 40 unless they're known to be higher risk. Dense breast, that 10%. So, again, those are the categories where the recommendations, the American College of Radiology suggests yearly MRIs for all those things with the question marks. NCCN, ask your doctor. American Cancer Society, ask your doctor. So we're on the fence. Some societies recommending MRI, some not. So there's not a clear answer. So some of it is know your doctor, know your biology, know how you manage risk. That's a huge piece. Do I worry more? It'd be better to get one, or should I get one and then I have to deal with the consequences of the false positives? Tough. It's a tough call. Risk models. This morning, I went into the IBIS model. This is how easy it is. You type in Google IBIS. The official name is, I think I misspoke into Tyler, not Tyler Cusick. Whoops. But it's IBIS. And you go in and you answer all these questions. It took me about 3 minutes, 3 to 5 minutes. A lot of questions about when I had my first child, when I started menstruation, if I breastfed, if I've had a biopsy in my family history. And at the end, it spit out a lifetime risk of 6.8%. Okay, probably because I'm a little bit older, don't have a lot of life left. So You know, I'm not 40. I'm not 40.
Come on, Kim.
I'm not 40.
Killing me here.
If I'm 80, it would be even low. I like the Tyler Cusick method the most, but you can go home and Google this and learn your lifetime risk based on that information. If you have any questions about it, obviously take that to your doctor. And if you have any additional questions, you can go to a genetic consult. Now, the tricky part about these, it won't tell you whether you're gonna get breast cancer or not. It's a population model based on statistics, okay? But I like the IBIS model the best. The Gale is frequently used as well. Some breast centers, as you answer the questions, in the intake form will spit out your lifetime risk. St. Joe's uses it, U of M will not, because they believe it's a little too tricky. And it's often misunderstood. So if you get your
It's in your
report,
report.
yeah, I believe it's in your report, yes. That your lifetime risk, so you can look on your reports, it's definitely in your intake form. So your radiologist knows what your lifetime risk is when you're getting your mammogram done at St. Joe's.
And how did the doc determine the lifetime risk? What did they use?
By the way, you answer the questions on the intake form. So you're in the waiting room,
With,
you got your iPad, they're asking you, when did you first menstruate? How many children have you had? Any family history, any biopsies? Personal history of breast cancer. That's how they spit it out. You can do that on your own this afternoon in 2 to 3 minutes, okay? Questions about the models?
For the Black women higher incidence, is that been determined to be a genetic thing or an environmental thing? Or, I mean, we know a lot that healthcare is disproportionate.
Yeah, equity issues,
Yeah.
probably all of the above.
Diet.
All of the above. I don't think there may be data that's better than that, but I think it's all. So access comes into that, socioeconomic status, diet. We know the higher your BMI, the more fat you have, the more estrogen you produce. Fat produces estrogen. Estrogen is not good. It grows breast cancer. Okay. So how do we diagnose? All right, you get your screening and 10% of you get called back. Okay, awful call, I know. The majority turn out to be nothing. Okay, the majority, you get a few more pictures, maybe an ultrasound breast exam, and they say, either come back in 6 months for a recheck or see you next year. That's the most. Sometimes it doesn't. You start with a biopsy. So you're gonna have a biopsy under ultrasound, or you're gonna have a biopsy in a fancy machine we call a stereotactic machine, where you lay on your belly and it's like changing oil in a car. It is. I'm under the table and I'm doing the biopsy like at Uncle Ed's. I swear. But we numb you up really well. And the women, for the most part, fly through it. Ultrasound is even easier. Sometimes we do it on MRI. That's much more complicated. So we have to have path. You don't get treatment unless you have path. Pathology. So you get a piece of tissue, you send it to the lab. That piece of tissue will tell them if it's cancer or not, or if it's pre-cancer. And that preliminary tissue will also tell them one of 3 things. Is it hormone receptor positive for estrogen, ER positive or negative? PR positive or negative, that's progesterone receptor positive or negative. HER2 positive. So most 85% of breast cancers are ER positive. Those are the good ones. That means they're well differentiated. They grow by estrogen. So that's why we want to know, how long has your body been exposed to estrogen? If you started menstruating at 9 and didn't get into menopause till 59, you have a long exposure to estrogen. Being pregnant will interrupt estrogen.
So having lots of babies helps.
Having lots of babies, it actually helps. Breastfeeding helps. Actually, not having one baby more. Yeah. So, you know, where we first started to find breast cancer is in nuns. realized the incidence of breast cancer in nuns was higher than women. There was no uninterrupted estrogen. Yeah, so that's what kind of led to some of this, this work. So most of the time you don't need the staging exams, MRI, CT, PET. Most of the time you go to the surgeon. If it's a relatively smallish cancer, they will offer you typically lumpectomy with radiation or mastectomy. Some women say, take them both off. I don't want to deal with this anymore. Some women say, I can't stand the idea of surgery. So much of this are personal decisions. Then we have to stage the lymph nodes. A new study is called sentinel lymph nodes. It used to be that every woman would have to get all mini lymph nodes removed from your armpit. Awful, because it would lead to decreased range of motion, but mostly lymphedema. You've probably seen breast cancer women have those constriction bands on here in the old days because they had a full axillary dissection, which has a lot of morbidity. Lymph nodes are one of our most important prognostic indicators of how you'll do after breast cancer. The smaller the tumor, the less likely you'll have a positive lymph node. Then typically lumpectomies are done with radiation, although there are exceptions in very low risk cancers in older women. Radiation time has come way down from 25 treatments now to 5 to 10. So that has changed. There is not only effective chemotherapy, but also immune therapy. So the ER positive cancers, that's kind of the better ones. PR is kind of neutral. HER2 new is a protein on the cancer cells. If you express that, typically your cancer is more aggressive. That's the bad news. The good news is that there are very effective immune therapies. Herceptin, it's called. Herceptin is the name that now can crush those HER2 positive cells. The worst breast cancer is what we call triple negative. It's a different kind of breast cancer. It's more aggressive, often shows up in younger women. We not uncommonly see it in Black women. Triple negative is a different beast. There is hormonal therapy and chemotherapy to help with that, but that's a different player. Okay, how do we prevent cancer? Know your risk factors. We all talked about what is the name of the score you're gonna go home and Google? IBIS, yes. So Tyler Cusick, IBIS model, you can do that, okay? Alcohol is a factor for, it used to be that little bit of alcohol was fine and we all love that. I'm having my red wine at night, not so much anymore, I'm sorry. They're basically saying, oh, alcohol is a risk factor. If there's really no protective or good effect from alcohol. Maintaining a healthy weight is important because excess adipose tissue makes estrogen. Estrogen makes breast cancer grow. Exercise and healthy diet, probably along the same lines. Less meat is better, they say. Smoking isn't a huge risk factor for breast cancer, but I think smoking follows other lifestyle choices that are not always great. And hormonal exposure is a big one. So we talked about when you started menstruating, hormone therapy after menopause. When I started mammograms, everybody was on hormone therapy. Everybody that was in menopause, like everybody. And then the big study came out that said, hold it, that's dangerous. And then everybody stopped going on hormone therapy. And there was a significant fraction of women that really suffered. So now we're kind of tipping the balance back to some women can use it for a small amount of time. If you have breast cancer, it's typically not something they recommend, and there's other ways to manage the hormone withdrawal problems. Okay, key references, American College of Radiology, American Cancer Society, NCCN. That one you have to sign in for, it's hard to get that information. USPSTF is some of those studies that the medical societies kind of jumped on and said, wait a minute, guys. NCI is the National Cancer Institute. So I left those kind of just comprehensive for you. There's other great ones, the Komen Foundation, Mayo Clinic. So stick with the foundations and the institutional ones you recognize. Yeah. Okay. Questions? Was that helpful?
Wow.
Oh, yeah.
Yeah, helpful. Great, great. What questions do you have? That's just kind of a start. Yes,
Okay, so, age 55.
55,
I
okay.
had, a screening, had a biopsy,
Okay.
ductal carcinoma in situ,
Perfect,
lumpectomy.
great.
Radiation, nothing else. And
Probably found it with calcifications on mammogram, I suspect.
probably
Calcs. Did you have the biopsy under ultrasound or the biopsy on the table?
had
where-
on the table.
On the table.
Mhm.
So they went after calcification.
Okay,
You are blessed.
yes,
It's as good as it gets.
yeah.
So essentially postmenopausal
Mhm.
and stage 0 breast cancer. No nodes?
No,
Perfect. That's, if you're to get breast cancer, that's exactly what you
right.
need.
I felt like for a long time, I just didn't even say I had breast cancer because it seemed so minor.
It's
And I'm now-
pre-cancer-ish.
Okay.
Yeah.
I'm now 74 and I've had no recurrence,
Fabulous.
which I think because I started taking vitamin D.
Vitamin D, we know there's a correlation. Were you put on tamoxifen?
They recommended, but I declined that.
And I think that's very reasonable, given what you had. So I would say you're doing great. Keep up the mammograms. So the question I think is, when do you stop mammograms? Okay, so you're 74, but you're healthy, you're fit, you're active. We say if it looks like you're gonna live at least 10 more years, keep going. Keep going. There's no end point at which we used to say 80. We don't say that anymore. Because there are, my favorite is when you get 292-year-olds to come in for their annual mammogram and go out to lunch. That's the best. Go in with your friends, go out to lunch afterwards, and everybody loves you coming in with your walker, or, it's just, we celebrate that. We celebrate that.
Is
So
there any glandular tissue left at 92?
shockingly, there can be.
Yeah.
Shocking. Yes, yes. So I would say definitely not a candidate for MRI. You're doing great. I'm assuming your density is probably scattered or heterogeneous.
I don't know that. I'm gonna look at.
Go
the
look at your
reports.
reports.
Yeah.
Yes. But I would say you got a great cancer and you had whole breast radiation, which is what we call local control. So that,
No, I was in a study
oh,
and they did a more
Focused?
intensive,
Okay.
focused kind of radiation,
great.
which I don't know if subsequently they started using that.
They can do that more, especially in women that have grade 1 or grade 1 or 2 DCIS. So there's 3 grades of DCIS. 3 is the worst, it's close to cancer. If you have a grade 1 or a 2, meaning the earliest of early DCIS, maybe we don't even need radiation, or maybe we just do local. So look back on your grade, look
Okay.
back on your density. And I'd say you're doing great. Whatever you're doing, keep doing it.
So here's a statistical question. If you were to go back in history of 1 to 200 years,
Yeah,
I would assume the rate of breast cancer goes up as you move forward in time. Is that a function of detection?
Yeah, yeah.
Or is that a function of actual occurrence or a
Actually,
combination of both?
it's, so what was so sad is before screening and breast cancer had a stigma to it. So women didn't talk about it. I mean, it was a sexual organ and it was awful and you didn't bring it up, you just died, right? There was no surgery for it and you didn't talk about it. It was shameful. The worst case, and we do see an occasional case like this, sometimes in even very intelligent women, because denial is such an incredibly powerful thing that we will see women have a lump, ignore it because it's too scary. Come in when it's growing through the skin. We still see that today, and sometimes in very intelligent women. So one of the reasons why we say, keep getting your mammograms, is the worst thing is to have a breast cancer and to be dying with the breast cancer growing through your skin. I mean, we don't want that when you're 80, when you're 85. So why keep doing the screenings and catching it and treating it just enough? Because we don't want that.
So I guess the other part of the question is, knowing that genetics is part of the catalyst that starts the cancer, what are the environmental, things that contribute?
Some of
Yeah,
them,
before you answer that,
Yeah.
if you're done with your slides.
yes,
why don't
take
we
it
turn off
down.
the
Thank you.
slide
Thank you,
so
Wendy.
People can see better.
Yeah, yeah.
And then,
It looks like
I
Larry's
saw a
done.
hand over here.
Right.
And Larry's got his hand up, so we'll
Okay.
make sure we give the Zoom.
So what are
folks
the
a chance.
environmental factors, what we talked about, but we all know, who knows? I mean, what we eat, what we breathe, what's in our water. We do know that in the last 20 years, we've seen an increase in young women with breast cancer, but we've also seen increases in young people with rectal cancer, with colon cancer, and it's awful. And we know it's more than a detection. It's awful. The incidence of these cancers is increasing. So something is going on.
Well, diet for sure.
Diet, carcinogens in our food and air and water supply. Yeah.
So I know Ann had a question, and then after Ann, we'll go to Larry.
Okay, I'm an architect, but I do a lot of work with healthcare, and I was surprised in some of the clinics that I was designing, and it was more for the VA, but that they were, bringing up that men
Yes.
needed to get, breast imaging done. And, I don't know how common it is, and I don't know how a man would find that out, because you said there's not maybe a blood test for it, but it sounds like maybe it's more of a genetic component. But I was thinking, well, like for soldiers, there's probably more environmental factors, which
Yeah.
might be part of why. But the thing about it was, breast centers are designed for women. And
Correct.
they had this thing where, well, you kind of need to have a separate entry or a separate way.
Yeah.
Because you don't want it to be this pink, purple, whatever, for the
For
men.
soldiers, our manly
Yeah,
soldiers,
Right,
right?
and so I don't know how common it is, but, I don't know how a man would find out about that.
It's a great question. In our VA now, we have female soldiers and a significant percentage. So the screening facilities have to be present, or they have a partnership. Like the VA may have a partnership with the U, so you don't have to duplicate services. It's expensive to run a breast center. Men usually find it by feel. So it's not, maybe once a day I may have a male patient who comes in with something they feel. And it's usually what we call gynecomastia. It's men that are teenagers and men that are getting older, where their hormones are changing and they develop little breast buds. And often it's on one side. And they come in and they say, oh my gosh, this is really hurting. And they have a little breast tissue growth. And it's because of imbalance of hormones in those two categories. We also see it with marijuana use, with many medications, and with anabolic steroids. So it's usually something men can feel. Men do get breast cancer. If there's a BRCA gene in the family, they may be more at risk for that. BRCA puts you at risk for prostate, pancreatic, breast, and ovarian. So if they're no BRCA carriers, they probably won't do screenings with mammograms, but they will do exams. But we typically will do a mammogram on a man, no problem, and usually an ultrasound.
Larry. Oh,
I think he's muted.
I don't think
Larry's not
He's not
muted.
muted.
Hold on just a second, Larry. I don't understand why,
Maybe his volume, maybe it needs to turn his volume up.
I mean, the owl should be picking up everything.
Can you put it in the chat?
No, there's unmuted again.
No. Larry, for some reason, your sound's not coming through. Can somebody else speak just to make sure that,
Larry.
Okay, now he's muted.
so Tori or Karen or Deb or somebody, can you unmute and just say hello?
Hello.
Okay, so it's gotta be on Larry's end. Sorry,
Larry, can you
Larry.
put your question in the chat?
He's,
He
he
is
is on.
He's on-
He's unmuted, or maybe turn up your volume. Could be a setting we can't see.
Yeah. So if you, Larry, if you can put your question in the chat, that would be great, because we can't hear you for some reason. And we're hearing other people who are online. Okay, so while Larry works on his question, other question.
So when should you start screening? If you're an average risk patient? 40. How often should you be getting a mammogram? And thank you.
You didn't know there was gonna be a test.
Why do we screen? Size matters. Size matters a ton.
So meat, all meat, not just red, not.
Oh, you know, I really can't speak to the dietitian studies, but we're worried that the meat consumption is also increasing the incidence of colon and rectal in young people.
I'm not a young.
The more, well, I think that the more kind of healthy plant substitutes, some of that vegan stuff is so processed, I'm not sure that's healthier. But I think, unprocessed, you know, the bottom line is unprocessed real food with a limited consumption of red meat and alcohol.
Would the meat component be a function of the steroids and antibiotics that are
Could be,
put in the animals?
Yeah, grass-fed
Could be.
organic would be.
yeah. Grass-fed when you can, you know, it's not always possible, it's more expensive. Just, you know, kind of a balanced approach to it.
I just read an article that said that fructose stimulates growth in cancer cells in vitro and in mice.
Glucose in general, if you can get rid of the sugar in your diet, glucose in general makes tumors grow. Because if you have glucose in your system, it produces insulin. Insulin upturns growth. It's a growth factor. So, yeah, eliminating processed sugars. And I mean, in general, healthy diet, eliminate processed sugar, limit red meat, limit alcohol. Take out the white stuff, take out the white bread and the white, I love my white bread. And my chocolate at night.
Well, Angelo's is closed now, so there's
Thank
my
goodness.
source of white bread.
Pasta, yeah, I mean, not all the time, do it 80% of the time. We have to live too, right? We have to enjoy life.
Okay, any last questions? We're coming to the end of our
Oh, yeah.
hour or period.
Yeah, sorry, Larry, we can't hear
I don't
you.
think he-
The
I
other
don't
thing
think
I
he
would say,
understands to
the
put his
other
question
thing I
in the
would
chat.
say about.
Sorry about that.
About screening is, all right, you go to your doctor, you say, I want a mammogram this year. Oh, you don't need it, you had one last year. So, you can just say, I would like one this year. And they said, well, we're not sure if insurance will cover it. And when anybody asks me price or insurance, you have to call your insurance company. You know, what the package you may have. And then you have to decide what the out-of-pocket cost is if you're gonna do that. And you know, American College of Obstetricians and Gynecologists have their own recommendations. So, you know, just have a discussion. As a mammographer that does this every day, I go every year. I go every year and get 3D.
That's
Some
what's
insurances will
recommended.
cover diagnostic screening once a year
Should,
and not, I mean, we'll cover
diagnostic.
screening, but not diagnostic.
They should cover diagnostics. I mean, diagnostics is a workup for breast cancer.
Well, let you know you have it.
Yeah, have you ran into or
So screening is
covered,
I'm in Medicare,
right?
but I have a Advantage plan.
Okay.
So screening is covered once a
Okay.
year, but diagnostic has
What's
limits.
the difference between diagnostic and screening?
Great question. Screening is when you have no problem. So you go in to get your mammogram, you don't have a lump, you don't have pain, you don't have nipple discharge, you don't have dimpling. You're just going in to get your annual done.
And you haven't had a problem in a year.
Yes, and you haven't had a problem, thank you, a problem in a year. If you have a problem, you have new nipple symptoms, lump, palpable findings, thickening, distortion, etc., then you go in for a diagnostic. You could have had a mammogram 3 months ago and it was clean. You still need to go in and you need to get a dedicated exam that often includes a breast physical examination and an ultrasound. We can't do MRIs on the spot, we can schedule. Rarely are those used in diagnostic settings.
But those are the ones with limited coverage, you're saying, Susan? Or,
So for my insurance, which is Medicare, which is standard of Blue Cross, a screening is allowed once a year and
Yeah.
you're covered. But then once you have a diagnostic at U of M, and they recommend you come back in 6 months, then that becomes screening again. That becomes diagnostic again,
Yes,
whether you like it or not.
yes, the
You don't
6
get to
month, the
choose.
6 month follow-up should be a diagnostic. Then the year follow-up should be a diagnostic, and then a year from then, usually 2 years and you're done in a short-term follow-up.
Yeah.
And it's, I don't know if that's because of the diagnostic or the deductible that you have to meet, it could be. But I always say, these are questions you have to ask your insurance agent about, or a company about. Yeah. Like if you wanted an MRI, regardless, like you just, I just want one.
So this is Part D. This is Medicare Part D added
I
on.
don't know the letter.
Okay.
Part D is medications.
From-
Yeah.
Part C is.
The C.
C is
sorry,
the
C.
additional plan, right?
D,
Not
right.
sure.
Yeah,
Okay,
And U of M won't allow me to to go back to a screening until I've
2 years,
fulfilled my time with the diagnostics.
2 years.
That's a lot of money. It's not covered,
Wow.
but they won't allow me to choose.
You're right, because we have to put you in a diagnostic slot. We can't treat you like a screener where we're reading 1,000 and we
Right.
have to treat you like a patient with a potential problem.
I don't understand why the insurance company covers screening and not diagnosis.
It doesn't make sense to me because you're trying to prevent breast cancer.
Right.
Right. It doesn't make sense to me. Yes,
Just don't get too excited when you go to your insurance company and do something bad.
Yeah.
we have a lot of problems with insurance companies. No,
okay.
it doesn't make rational sense.
Anything else?
Brian has the slides. Feel free to send them out to the group
Okay.
or post them or whatever.
I,
or send them to me and I'll do
yes.
it.
Wendy?
I can forward them to
And
Wendy.
did you take attendance, Wendy?
I did, thank you.
And if you have any questions, email me, text me, get me through church center. Oh, I'm a church center. Who's on church center? Yay! Yay! Okay.
More than 90%.
That was pretty good. If you're not on church center, want me to put you on right now, I can get you on very quick. I can help you for free, right here.